So asthma is characterized by hyper-responsiveness of tracheobronchial smooth muscle to variety of stimulus, resulting in narrowing of air tube, often accompanied by increased secretion, mucosal edema, mucosal plugging that may produce dyspnea, wheezing, cough, and leading to limitation of activity. Alright, so hypersensitivity. So asthma is basically hyper-responsiveness to some or other allergen. Some may be allergic to house dust mite or to pollen. So what happens? That leads to constriction of tracheobronchial tree. So in the tracheobronchial tree there are smooth muscles. So there are contraction of smooth muscles associated with inflammation. So inflammation is carried out by inflammatory cells and there are inflammatory mediators. कल्पार्थ किसी inflammatory mediators and number. Inflammatory mediators. Anyone? Interleukin, cytokines, inflammatory cells, macrophage. ठीक है जी? What Pritam has said, somewhat right. So let's go deep into it. So this is a normal cross section of bronchioles, the terminal bronchioles. So what you can see here, there is a epithelial lining. So what type of epithelium? What type of epithelium? Ciliary epithelium. Why ciliary epithelium? Because there are secretion of mucus that has to be cleared out, and this ciliary epithelium cleared this mucus. Then you can see that the wall is thin. Alongside the wall there are blood vessels where the exchange of gases takes place. So these are terminal bronchioles. Alright. So here the muscle layer is, the smooth muscle is very thin. Alright. So this is cross section of bronchus. So similarly there is ciliary epithelium. There are this smooth muscle layer surrounding the epithelium. So contraction of this smooth muscle layer leads to constriction of the bronchus. That leads to restriction of airflow. So what will happen if there is restriction of airflow? Hypoxia. Dyspnea. What do you mean by dyspnea? Difficulty in breathing. Alright. So there are this epithelial layer and the smooth muscle layer. Then we come to innervation. So the respiratory system is innervated by parasympathetic. So respiratory system has only parasympathetic innervation, no sympathetic innervation. So which nerve? Vagus. So there is only parasympathetic innervation. So these innervation, so here you can see they are the nerve terminal are releasing ACH, acetylcholine, and the post ganglionic receptor are M3, chiefly M3. Alright. So what will happen if M3 receptor are stimulated? Bronchoconstriction, ঠিক আছে, and there will be increased secretion of mucus, ঠিক আছে. Now then we come to the chief receptors. So M3 receptor for the parasympathetic system causes bronchoconstriction. Beta 2 receptor. Now there are no sympathetic innervation. So what is the function of this beta 2 receptor? Bronchodilation. But where is the ligand coming from? The ligand is coming from the adrenal gland that produce adrenaline that act on the beta 2 receptor. Alright. So there are no innervation, but the receptors are activated. Then we come to the pathophysiology. Inflammation and airway hypersensitivity. So type of hypersensitivity reaction, anyone? চারটে টাইপ আছে, ঠিক আছে. So what is the characteristic of this hypersensitivity reaction? In our inflammatory mediators তো inflammation এর সময়ও হয়, ঠিক আছে, and airway hyper-responsiveness. So airway hyper-responsiveness and inflammation. Inflammatory cell, as Pritam has said, inflammatory cells and inflammatory mediators. So there are two phases. First is the slow phase, then the rapid phase. Alright. So we will look into it later. Achha, the cell involved. So you are familiar with these cells. There are mast cell. Mast cell produce histamine. Alright. Histamine is responsible for hypersensitivity. ঠিক আছে, leads to bronchoconstriction. ঠিক আছে, macrophage and dendritic cell. These are, what are these? Function key. These are antigen presenting cells. Alright. They do phagocytosis and present the antigen. Eosinophil. Eosinophil contains, releases again histamine. ঠিক আছে, neutrophil, lymphocyte. So these are all inflammatory cells. They produces various types of chemical mediators. Alright. বিশ্বাস এসছে অনেকদিন পরে। আচ্ছা, then there are epithelial cell, fibroblast and smooth muscles. Smooth muscles, what is the significance of smooth muscle? Contraction of smooth muscle leads to narrowing of airways. ঠিক আছে, repeated activation of smooth muscle leads to hypertrophy of smooth muscle. The smooth muscle becomes much thicker in patients suffering from chronic asthma. Then we come to inflammatory mediators, cytokines, chemokines, growth factor. One of the most important of them is leukotrienes. Alright, histamine, prostanoids. So what are prostanoids? Prostanoids, anyone? Okay, so one chap, Indad. এই পড়াশোনা হচ্ছে না, inflammation is a basic thing that is taught in pathology. ঠিক আছে, NO, nitrous oxide. What is the function of nitrous oxide? Vasodilation. Here it leads to dilatation of the smooth muscles, the bronchodilation. ঠিক আছে, now effect. What will be the effect? bronchospasm, ঠিক আছে, constriction of the smooth muscles. Then plasma exudation. What is exudate? Mucus secretion. Mucus are secreted from the which cell? Goblet cell, ঠিক আছে. So mucus, there is excess mucus secretion leading to mucus plug, ঠিক আছে. Airway hyper-responsiveness and structural change. There may be hypertrophy of the smooth muscles. So let's find out. There is the allergen. Allergens are taken by macrophages. So then what happens? Macrophages and dendritic cell, they produces chemotactic agent. They recruit various types of cell. Eosinophil, neutrophil, T helper cell, these are recruited into the system, the respiratory system. They again produces some inflammatory mediators. Alright. So that leads to inflammation. First there is presence of some allergen which triggered the process, then there is inflammation. What happens when there is inflammation? There is exudate. Exudates are produced. ঠিক আছে? There is excess secretion of mucus. There is sloughing of the epithelial layer that may lead to exposure of the nerve ending, irritation of the nerve. So all these things contribute to the constriction of the bronchus. The terminal bronchioles basically are more susceptible, ঠিক আছে. So the constriction of the bronchioles, alright, and blockage of this alveolar air space by the mucus, the sloughed out epithelial cells and exudate. They all cover the alveolar space. So what will be the result? What will happen? There will be difficulty in exchange of gas that will lead to respiratory distress. ঠিক আছে? So where can we intervene? This is the pathological process. Where can we intervene? We can make sure that there is no recruitment of the inflammatory cells, or there is less formation of chemical mediators, or something to make the smooth muscles, that is the bronchial smooth muscle, relax. So now we come to the chemical mediators. So majority of chemical mediators are derived from arachidonic acid, ঠিক আছে, the phospholipid. So there is phospholipid from which arachidonic acid is produced. Then there is the cyclooxygenase pathway and the lipoxygenase pathway. From your knowledge of biochemistry, পড়েছিস তো? So the COX pathway produces thromboxane, prostaglandin, prostacyclin, ঠিক আছে, and the lipoxygenase pathway produces leukotriene. Leukotriene is one of the major chemical mediator of asthma. Alright. So what does this NSAIDs do? NSAID means non-steroidal anti-inflammatory drug. বল কি করে? ইমদাদ। inhibits, তোর নাম কি? Tonnistar. As Tonnistar is rightly stated, inhibits the COX pathway. Alright. So in some individual it happens that when the COX pathway is blocked, the arachidonic acid shifts to the LOX pathway, alright, and produces leukotriene that leads to precipitation of asthma. This is known as aspirin induced asthma. So these steroids These are the substances that inhibit production of these inflammatory mediators. So steroid is one of the drug used for controlling of asthma. Okay? So here you can see this is the upper part is a normal respiratory pathway. There is this ciliated epithelial layer, there is this smooth muscles, there are these blood vessel. Now this is an cross section of an asthmatic, the lower part is the cross section of an asthmatic airway. So what you can see, the ciliated epithelial cells are sloughed off, there is hypertrophy of the smooth muscle, there is exuded and mucosal secretion within the airway. Alright. This is how an asthmatic airway looks like, and of course there is plenty of inflammatory cells. So phases, there is an early phase and a late phase. So early phase is the when the allergen gets into the system. Alright. So what happens? The macrophages engulfs it and they send out signals. That is the early phase. And the late phase is the phase when inflammatory cells are being recruited. When the inflammatory cells are being recruited, they start to produce inflammatory mediators. So types, two types, extrinsic type and intrinsic type. What do you mean by extrinsic type? Extrinsic type is where the allergen is known. So you know what is the triggering agent. Suppose if a person is allergic to dust or to pollen, you know that when spring comes, there will be triggering of asthma. So these type of asthma are generally not much of severe and they occur seasonally after the exposure. And another is the intrinsic type. In intrinsic type, the allergen is unknown. So how do you diagnose? So this is PEF, forced expiratory volume in first second, forced expiratory volume in first second by forced expiratory volume. So this value is typically more than 70%. Alright, 70 to 80%, that is the range normally. If that is less than 70%, it is more likely to be asthmatic, though there are other diagnoses also. Skin test কার জন্য করা হয়? Allergy. ঠিক আছে? Now we come to the drugs. Beta 2 agonist. So what does beta receptor does in the tracheobronchial system? Bronchodilation. ঠিক আছে? So there is long acting beta agonists, LABA, Salmeterol, Formoterol, Bambuterol, Indecaterol. ঠিক আছে? So know this name very well. Short acting beta agonists, that is Salbutamol and Terbutaline. So in practical, these metered dose inhalers are given. Along with this metered dose inhaler, some questions are asked. So this year the metered dose inhaler was given and there was Salbutamol was there and two other drugs of the same class was asked. এটা কিন্তু প্রশ্ন ছিল, তা কেউ কিছু লেখেনি, ঠিক আছে? So nobody could name any other two beta 2 agonists. So know this name very well. ঠিক আছে? Short acting. So short acting one are fast acting and long acting one are slow initiation but long acting. So what are the uses? What may be the uses of these two? Well, short acting এর কি use হবে, long acting এর কি use হবে? So short acting will be used in termination of acute conditions, acute asthmatic condition. ঠিক আছে, তোর নাম কি? তোর পেছনে সাগর. And long acting, so long acting will be used in prophylaxis. ঠিক আছে, যাতে নাকি না হয় তার জন্য ইউজ করা হতে পারে. Alright. So how does beta 2 receptor acts? So this is a G protein coupled receptor. So this is a beta receptor, it's a G protein coupled receptor. It stimulates adenyl cyclase that leads to production of cyclic AMP. So what does this cyclic AMP does? They increase the outflow of calcium and uptake of calcium in the sarcoplasmic reticulum. So what is the function of calcium in smooth muscle or any muscle? Constriction. So any muscle to constrict, it requires calcium. So since the calcium is being, the level of calcium is being lowered, it leads to leads to bronchodilation. ঠিক আছে, and it has another property. It causes the potassium to move inside the cell. So what will happen to potassium level? Potassium level will decrease. So what will lead to this phenomena? Influx to ইনসাইড চলে যাবে, তাহলে সিরাম পটাশিয়াম লেভেলের কি হবে? ইট উইল লিড টু হাইপোক্যালেমিয়া. ঠিক আছে, সো the potential ADR of these beta blockers may be hypokalemia. ঠিক আছে, and how can this property be used for our benefit? In hyperkalemic patient, if we use beta blocker, there will be decrease in potassium, so that can be used in case of hyperkalemia. ঠিক আছে, what is the normal range of potassium? Anyone? Vidipta? 3.5 to 5 milli equivalent. ঠিক আছে, 5.1 বলে, কেউ কেউ 5.5 বলে. ঠিক আছে, so that is the normal potassium level. So why should that potassium level be maintained? What is the danger of hyper or hypokalemia? Arrhythmia. ঠিক আছে, so তাহলে কি হবে? G coupled receptor, relaxation of smooth muscle. Smooth muscle, here it is bronchial smooth muscle. Inhibit release of mediator from mast cells. What are the mast cells? Release, ki release kore? Histamine, one of the important mediators. Then inhibit sarcovascular leakage. So why is leakage important? That causes the exudates. Alright. Then increase ciliary clearance. Acha. Now we come to the route of administration of this beta agonist. Route, prerona, inhalational route. ঠিক আছে, so these are administered by inhalational route, and device এরকম দেখালে হবে না, meter dose inhaler. Alright, inhalational route and meter dose inhaler. So what is the advantage of giving this medication by metered dose inhaler? বল কি জানো তোর নামটা বললে তনিষ্ঠা. So what Tonishta has said, it goes directly at the site of action. No fast metabolism, little systemic effect. Alright, directly goes at the site of action and produces the action and fast onset of action. ঠিক আছে? Now these agents are beta 2 agonists. Alright, so can a non-specific beta agonist produce such thing? Side effect হয়ে যাবে. ঠিক আছে? So what are the other places of beta receptor, other receptors and its location? Heart. Okay, beta 1 receptor is there in the heart, that will lead to what? ঠিক আছে, most important is the heart, that lead to increase in heart rate. Alright, increase in heart rate, increase in contractility. ঠিক আছে? So these are beta 2 agonists, so it is safe in case of cardiac patient, and also it is administered via inhalational route, either by nebulization or by metered dose inhaler, whatever be there. Acha, short acting, faster onset, ideal for termination of acute attack. Long acting, slower onset, ideal for prophylaxis in association with inhalational corticosteroid. Name some inhalational corticosteroid. Sengupta. বল, বিদিপ্তা কিছু বলতে চাইছে. Viclomethazone. ঠিক আছে? So given predominantly by inhalational route, limited ADR. So what are the ADR? There may be tremors and there may be hypokalemia. ঠিক আছে? আচ্ছা, then we come to anticholinergic. We have seen that there are innervation by parasympathetic system. তাহলে what does parasympathetic system does? It causes bronchoconstriction. Now here we are giving M3 blocker. So what are these? Ipratropium bromide, tiotropium bromide, glycopyrrolate. Now these M3 blockers are more effective in case of COPD, chronic obstructive pulmonary disease. Alright, so there was once question asked, name some drug for COPD. So all sorts of things were given other than these two names. ঠিক আছে? তাহলে COPD এর জন্য ipratropium bromide, tiotropium bromide. Like beta agonist, there is SABA. So short acting muscarinic antagonist. Alright, and tiotropium bromide, long acting muscarinic antagonist. So like this is used for termination of acute attack and this is for prophylaxis. ঠিক আছে? So these are less effective in asthma, used along with other bronchodilators. Usually ipratropium bromide and salbutamol are used together. Predominantly used in COPD. Question was asked, drugs for COPD. So answer was horrible. So please remember it. Methylxanthine. So methylxanthine, any naturally occurring methylxanthine that you consume every day? Theophylline ki khas? Tea te thakbe, So caffeine, theophylline, these are present in tea and কফি, অলরাইট, চকলেটে থাকে। সো what are the effect of this methyl xanthine? Sengupta, what are the effect of this theophylline and caffeine? কেন খায় লোকেরা? ব্রঙ্কোডাইলেশনের জন্য টি এন্ড কফি খাচ্ছে, কেন খায়? আমলাও খাস না, চা খাস না? So these are primarily they cause bronchodilation, তো এখানে হচ্ছে। So these are also CNS stimulant, ঠিক আছে? চা খেলে এনার্জি আসে, তাই তো? দেয়ার যেমন পার্থর খুব ঘুম পাচ্ছে, ঠিক আছে? So these are primarily CNS stimulant. So some name theophylline, aminophylline. Acha, so problem with this methyl xanthine is that they have very narrow margin of safety. What do you mean by margin of safety? Sengupta, জানিস না? তাহলে তুই এখানে এসে বস, ওখানে এসে আড্ডা মারলে কিছু হবে না, এখানে এসে বস, ইংরাজদের পাশে এসে বস, ঠিক আছে? So they have narrow margin of safety. What do you mean by margin of safety? Anyone? Somewhat like that. What she has said is right. So you have to use it very carefully. ঠিক আছে? So they have long half-life. Oral, slow IV. The problem with oral is they have high fast metabolism. ঠিক আছে? But they are given slowly, very slowly if given IV, either by infusion or by drip, whatever may be that, they are given slowly because they have effect on cardiac muscle. So they can increase the force of contraction of cardiac muscle. They can at higher dose may cause arrhythmia. ঠিক আছে? পাত্ররাজের প্রচন্ড ঘুম পেয়েছে। So what are we using it for? Using it for bronchodilation. Earlier theophylline was a popular drug. Now it is not much of a use because it has very low margin of safety. Then it causes stimulation of CNS and heart. Then diuretic action. If you drink much of coffee, you feel like going to toilet. Then dilatation of blood vessel. Then gastric irritation, that will lead to gastric irritation বললে কি হবে? হ্যাঁ, বল সাগর বল। ডায়রিয়া, হ্যাঁ ডায়রিয়া হতে পারে। আর কি হবে? গ্যাস্ট্রাইটিস হবে, ঠিক আছে? ইনক্রিজ স্কেলিটাল মাসল contraction, ঠিক আছে? Now how does this mechanism of action of theophylline? So in the earlier picture, so here is this CAMP. Now what happens to this CAMP? What is the fate of this CAMP? This CAMP is being metabolized by phosphodiesterase. প্রীতম যেটা বলেছে phosphodiesterase. So what will happen if phosphodiesterase is inhibited? CAMP level বেড়ে যাবে. So beta agonists were increasing the CAMP level by production, and theophylline, they inhibit phosphodiesterase enzyme. So they increase CAMP by prohibiting its destruction. So they increase CAMP by reducing its destruction. So CAMP level is being increased. So inhibit phosphodiesterase 2, phosphodiesterase 3 and phosphodiesterase 4. ঠিক আছে? Phosphodiesterase 3 causes smooth muscle relaxation. Phosphodiesterase 4 is present in eosinophil and mast cell. They inhibit release of the granules. ঠিক আছে? Block adenosine receptors. So adenosine is কি করে? adenosine vasodilatation আর আচ্ছা ঠিক আছে ছেড়ে দে আচ্ছা it has narrow therapeutic window from 5 to 20 microgram অনেক এক্সামিনার অনেক পুরনো এক্সামিনার এটার রেঞ্জটা জিজ্ঞাসা করে ঠিক আছে 5 to 20 microgram ঠিক আছে drug induction with enzyme inducer and enzyme inhibitor. What do you mean by enzyme inducer and inhibitor? Inducer and inhibitor মানে কি? So enzyme inducer and enzyme inhibitor কিন্তু শর্ট নোটে আসে জেনে নেবে ঠিক আছে so rifampicin phenytoin carbamazepine they induce enzyme what will enzyme induction lead to faster metabolism ঠিক আছে and enzyme inhibition lead like erythromycin ciprofloxacin they will lead to increase in concentration and the body is sensitive to the concentration of the theophylline ঠিক আছে then we come to the mainstay of treatment corticosteroids what is the function of corticosteroids কি করে inflammation suppresses the inflammation it both reduces the cells and the mediators it have effect on both of them it is not a bronchodilator ঠিক আছে now there are oral prednisolone methylprednisolone parenteral hydrocortisone and inhalational বিদীপ্ত বলল inhalational budesonide diclomethasone fluticasone cyclosamide ঠিক আছে এটাও কিন্তু প্র্যাকটিক্যালে দেয় মিটার ডোজ ইনহেলার থাকলে তার সাথে কোশ্চেন থাকে what other inhalational corticosteroids name two other inhalational corticosteroid ঠিক আছে তো আগেরবার না তার আগেরবার দিয়েছিল তাতে লিখেছিল prednisolone so prednisolone is an oral corticosteroid not an inhalational one ঠিক আছে এই নামগুলো একটু ভালো করে জেনলো আচ্ছা what is problem with oral corticosteroid হ্যাঁ কুশিং সিনড্রোম ঠিক আছে ওভারডোজ হয়ে গেলে কুশিং সিনড্রোমের মতন দেখাবে so what is কুশিং সিনড্রোম I hope you all know it ঠিক আছে আচ্ছা parenteral corticosteroid hydrocortisone কোথায় ইউজ করা হবে in case of emergency ঠিক আছে IV দেওয়া হয় corticosteroid is hydrocortisone ঠিক আছে and then there is inhalational corticosteroid advantage the same as that of inhalational beta agonist directly গিয়ে একেবারে সাইট অফ অ্যাকশনে কাজ করবে has very low adverse effect ঠিক আছে and faster action আচ্ছা তাহলে inhalational corticosteroid কি করবে it reduces the synthesis of all these chemical mediators ঠিক আছে this is effect on chemical mediators so it reduces inflammation and in cell it reduces the number of all the inflammatory cells ঠিক আছে এক তো it prevents the recruitment of the cell and secondly it also promotes apoptosis of certain cell like the eosinophil it promotes apoptosis in eosinophil so the cell number is reduced so inflammatory mediators are reduced cell number is reduced so what will be the net effect so there is lowering of inflammation ঠিক আছে so inhalational corticosteroid this is the mainstay of treatment of asthma ঠিক আছে combination with beta agonist causes bronchodilation and this controls the inflammation then inhibit release of mediator inhibit production of mediator lower inflammatory cell upregulation of beta 2 receptor so that is synergistic action all right that upregulation of beta 2 receptor on which the beta agonist may act. Then used for prophylaxis. Now the problem with inhalational corticosteroid is it's a immunosuppressant. তাহলে কি হবে? There may be presence of oral candidiasis or oral thrush in the mouth. There may be hoarseness of voice. So what is the treatment? What is the remedy? Wash your mouth after taking meter dose inhaler. That is the remedy. Oral corticosteroid. So may be used for prophylaxis in extreme cases of asthma. ঠিক আছে? Then use after termination of acute attack to prevent further attack. Then the ADR, like Pritam has said, there will be Cushing syndrome like ADR. So parenteral hydrocortisone terminate acute attack. Then we come to mast cell stabilizer. So what does mast cell do? It leads to secretion of histamine. আচ্ছা, নাম হচ্ছে সোডিয়াম ক্রোমোগ্লাইকেট নেডোক্রোমিল. Alright. So this year the examiner was asking name some anti-asthmatic drug. So the students started directly with chromoglycate. So what is the mainstay of treatment of asthma? Beta agonist, steroid. So if you are asked name some anti-asthmatic drugs, start with steroids, start with beta agonists. ঠিক আছে? These are only adjuvant drugs. They can act only for prophylaxis. They cannot terminate any attack. ঠিক আছে? So start with steroids, start with beta agonist. ঠিক আছে? Use for prophylaxis. Stabilizes mast cell, prevent degranulation in lungs. Combination with anti-inflammatory or bronchodilators. Leukotriene modulator. Leukotriene is one of the chief modulator of asthma. ঠিক আছে? So there is this 5-lipoxygenase inhibitor, Xileuton and receptor antagonist, that is Zafirleucus, Monteleucus. Now these two are also for prophylactic purposes. Once the reaction starts, they cannot terminate the asthmatic reaction. These are for prophylactic purposes. Some other use of Monteleucus, they are used in other allergic condition like allergic rhinitis. ঠিক আছে? So given orally, used for prophylaxis allergic rhinitis. আচ্ছা, monoclonal antibody, there is this name omalizumab. So this Zumab is a name for humanized monoclonal antibody. This is directed against IgE. What is the function of IgE? Anaphylaxis. ঠিক আছে? So IgE binds to the mast cells and causes degranulation of histamine. So by acting against the IgE, they prevent attack. Alright, these two is used for prophylaxis. ঠিক আছে? They cannot terminate attack. These two are used for prophylaxis, and omalizumab is highly expensive. ঠিক আছে? Given subcutaneously, it is highly expensive. This is given for uncontrolled asthma, extreme case of uncontrolled asthma. So some non-selective sympathomimetic like ephedrine, isoprenaline. ঠিক আছে? The problem is that they will produce adverse effect. They are given systemically and they will involve other organs also. আচ্ছা, roflumilast is a new drug, ঠিক আছে, is PDE4 inhibitor, ঠিক আছে. Now devices, what are the devices used? Meter dose inhaler. এই meter dose inhaler সবাই দেখেছে তো? meter dose inhaler কিন্তু আসে, অনেকে অনেক কিছু লেখে, so write the name properly, meter dose inhaler. Then spacer. Spacer, have everybody seen spacer? ঠিক আছে. Then rotailler, have seen a rotailler? So meter dose inhaler, there is this mist is being formed, there are some propellant and the active ingredient, so a mist is being formed that is being sprayed, and in rotailler the drug is being present in form of a powder, ঠিক আছে. nebulization মেশিন দেখা হয়েছে, ঠিক আছে. So something about the particle size will be 1 to 5 micron. Larger than 5 micron, the particle will be deposited in the upper respiratory airway, ঠিক আছে, and less than 1, it will go inside and will be breathed out, no function. So the size must be within 1 to 5 micron, and only 10% of the drug reaches the site of action. So that is the same thing, this is aerosol that is being produced, yeah, the targets to grinding drug. Now status asthmaticus, management of status asthmaticus comes as a question in theory examination, ঠিক আছে. তাহলে কি করতে হবে? So any management that is given to you, mention the name of the drug, the route of administration, dose of the drug, and if possible the duration of administration. Please mention these points, ঠিক আছে. একবার কোশ্চেন এসেছিল দি ম্যানেজমেন্ট অফ স্ট্যাটাস এপিলেপটিকাস ছিল, ঠিক আছে. So what I found out that people are writing simply the name of the drugs. That is not enough. What drug you are going to apply, their dose, their route of administration, and in which sequence they are going to be applied, all have to be there. বুঝলি? তো নম্বর পাবি না নয়তো। তাহলে কি প্রথমে কি হাইড্রোকোর্টিক, ঠিক আছে, 100 mg IV, ঠিক আছে. নেক্সট নেবুলাইজ সালবুটামল অ্যান্ড ইপ্রাটোপিয়াম ব্রোমাইড, দেন হাই ফ্লো হিউমিডিফাইড অক্সিজেন, ঠিক আছে. দেন ইফ নট কন্ট্রোল, তাহলে কি করতে হবে? সালবুটামল আর টার্বুটালিন IMR SC 0.4 milligram. Then intubation, if still not control, you need to intubate the patient and initiate ventilation, ঠিক আছে, assisted ventilated breathing. Then you have to maintain the acid base balance. So what happens during asthma? There is breathing, excess of breathing that lead to washout of carbon dioxide. So the bicarbonate level decreases. So there is acidosis. What can be given for acidosis? কি দেওয়া? Bicarbonate, ঠিক আছে. Bicarbonate lactate, and to maintain hydration you need some fluid, maybe NS, maybe RL, ঠিক আছে. Antibiotic therapy, prophylaxis, there may be associated infection of the chest that is being corrected by this antibiotic, ঠিক আছে. আচ্ছা, either a flow chart করে লিখতে পারো, or you can write it in points 1 2 3 4 5 6 like that, ঠিক আছে. So write it like this way, just নাম লিখে দিলে কিন্তু নম্বর আসবে না। কোনো কিছুর ম্যানেজমেন্ট বললে নাম লিখলে কিন্তু নম্বর আসবে না, নামের সাথে ডোজ আর রুট অফ অ্যাডমিনিস্ট্রেশন সবকটা দিতে হবে। বোঝা গেল? Now strategies: short acting beta agonist, intermittent one, maintenance therapy by low dose inhalational corticosteroid, add-on therapy, long acting beta agonist, additional control, low dose inhalational corticosteroid, Formoterol, multi-glucose. So these are how the asthma are controlled. This is the same thing in stepwise manner. Acha, question comes about long question comes from asthma. ঠিক আছে? Enumerate the drugs used in asthma. What do you mean by enumerate? Huh? Enumerate মানে কি? বিদিতা? হ্যাঁ? নামগুলো লিখতে বলেছে, ঠিক আছে? Either you can mention the class and the name, ঠিক আছে? If you forget the class, write only the names. So write it properly. This is a picture given in your KDT. If you can write it in this way, it is very good. Examiner will have it easier to check your copy. ঠিক আছে? It fetches very good mark. ঠিক আছে? So there are bronchodilator like beta agonist, methylxanthine, anticholinergic, mast cell stabilizer, leukotriene antagonist, corticosteroid, IgE. So if you can give it like this way, that will be good. Or you can give it in numerical form 1, 2, 3, 4, 5, 6. ঠিক আছে? So if enumeration comes, whichever way you like to give it this way, by giving it in this way you can get good marks. বুঝলি?